Now in this module we will be seeing something on type 1 diabetics. When it comes to type 1 diabetes, insulin pumps really scores. So we are not going to see about insulin pump. How to manage your type 1 diabetic patients in a pure professional way. That is what we are going to discuss in this session. The principles that guide the insulin pump, how can we stimulate all those principles in real life and manage the patients in a better way. That is the objective of this module. So we'll be seeing exactly 5 points on this, which are essential for the management of type 1 diabetic. This is the objective of this module. So we'll just, for the discussion's sake, we'll just take a much complicated case. Mr. Sam, he is 31 years old, 70 kgs. He is type 1 diabetic for the past 6 years. He is on co-formulation. When we mean by co-formulation, it is about a long-acting insulin, which comes in the name of Rheumatology, which is the costliest insulin available as of now in the market. So the co-formulations, which is a long-acting insulin with a short-acting analog. This long-acting insulin has got a ultra long-acting, means it can act for even more than 24 hours. And the short-acting insulin aspart, which can take care of the meal stimulation, meal stimulated glucose increase. So he is on the mixture of these two insulin, which he is taking twice a day for the comfort. So he is about 38 units in the morning and 24 units he is taking, and his HbA1c is about 10.1. So this brief summary will suffice for discussing this patient. We will not get into the other details. We are going to deal about how to manage this patient's blood sugar very comfortably. So as we see, this co-formulations, as I said, it is a mixture of long-acting insulin and a short-acting insulin. So both these are all analog, and this long-acting insulin will act for more than 24 hours, which gives a benefit. And this short-acting insulin acts for, these are all the aspart. We discussed about aspart in the previous module. So these will take care of the meal, and he is not taking anything for the lunch. So what we want you to know from this is, so as we see, the blood sugar of the individual didn't get controlled at all. So if you see, like his HbA1c is about 10.1. We are using a costlier insulin which is available in the market, but in spite of it, his blood sugar is not getting controlled. Now for this individual, so if we try to increase the long-acting insulin or a short-acting insulin, what will happen is, so this is a premix insulin, this is a premix insulin. So what will happen is, this is what his glycemic excursions are. These are the glycemic excursions, and this is the long-acting insulin profile, and a short-acting insulin which is acting over there. So this, what actually happens to these individuals when they are on this mixture of a short-acting and a long-acting insulin is, so when we try to control the overall day or the basal requirement with a long-acting insulin, so since it is in a combination of 30-70, this is not premixed, this is called as co-formulation. Rather than calling it as a premixed insulin aspart, this is called as co-formulation. Or we can use this type of insulin also. We can use a premix insulin, where the premix insulin, what we mean by premix insulin is, the 30 parts will be a short-acting insulin analog and 70 parts will be the NPH insulin. Whereas here the long-acting insulin will be degludec. So that is a long-acting insulin. Short-acting insulin, both the formulations is going to be the aspart insulin. Now, when we try to take care of the long-acting insulin, when we try to increase the long-acting insulin to take care of the basal part, when the fasting is not getting controlled, automatically we are increasing the short-acting insulin also, whereby the patients will be more prone for hypoglycemia. So this is the disadvantage. So why? Because this part we are trying to increase, automatically this part also will increase. So the patients might be prone for hypoglycemia because of this fixed formulation. Now, in case if his meal stimulated insulin is higher, we may be trying to increase the dose of this insulin. So this part we are trying to insulin. So automatically this part also will increase. So whereby it will cause, and again, hypoglycemia. So it doesn't give the balance. So when we try to increase this, this is also indirectly we are increasing the short-acting insulin. predisposing the individual to hypoglycemia. When the short-acting, when the meal sugars are not getting controlled, when we try to increase the short-acting insulin, the long-acting insulin dose also automatically, because of the premixed nature, it gets increased, and that predisposes them to hypoglycemia. So this doesn't give the flexibility of addressing the hyperglycemia without causing an undue hypoglycemia.